good evening, everybody, and welcome to another conversation with a doc. We have Dr. Jori Fleisher on call here, and we're very pleased and lucky to have her. I don't know her personally yet, but I'm going to let her introduce herself. As usual, you feel free to chat or raise your hand. And we hope that you will. Once again, I'm going to ask you to please fill out the evaluation that we're going to send out right after this. It will really help us if you would fill it out, and we'd appreciate it. So with that, I'm going to turn it over to Dr. Fleischer.
Thank you so much, Judy, and thank you to Mike behind the scenes. It is such an honor to talk with you all tonight. It is such a pleasure to be with you. So as Judy said, my name is Dr. Jori Fleischer. I am a movement disorder neurologist. That means I see people with Parkinson's and Lewy body and related stuff all day, every day. I'm no good at a party because this is my baby, aside from my two babies. And I am practicing at Rush University in Chicago, and very passionate, especially my research and my clinic in the last really 15 years have kind of evolved to focus on individuals with later stage Parkinson's and related disorders, and recognizing just how much we don't do and how much more we could be doing, not only for people living with the diagnosis, but for their care partners and their family members too. So with that, I'm going to talk with you today about caring for Parkinson's caregivers, and I'll use the term caregivers and care partners and carers interchangeably. Some people feel very strongly about the term caregivers, and they do not like care partners. But I've also heard just as many people say, I don't identify as a caregiver, I identify as a care partner. So I'm sure whichever term I use, it is probably not okay with someone, and I'm sorry, and I will try to switch off between them all. But we're going to talk today about some unique challenges and novel approaches to support. But I'm happy to answer any questions at the end about anything too. So here's our horizon for the talk is we're going to talk about Lewy body dementia, and I'm going to explain why we're talking about Lewy body dementia in a Parkinson's support group. And we'll talk about Parkinson's and then outcomes, but more so, what do we know about the folks behind the scenes? What do we know about caregivers, care partners? And what can we do right now today to help better support care partners and the people who they love? So with that, I said I'm going to talk about Lewy body dementia, and I recognize that this is a Parkinson's support group. So what is she doing here? Okay, this is really, really confusing. And I will say, if you have heard the term Lewy body dementia as someone affected by or living with someone affected by Parkinson's and gone, I don't know what this is. Does this apply? Does this not apply? You are not the only one who's confused. Our entire specialty, all of movement disorders, all of cognitive neurology, we're all confused, and everyone argues about this. Here's the problem. I really like stupid analogies. So one of my favorite stupid analogies is to think about this problem as a chicken and an egg problem under an umbrella. And I'm going to explain what this means. But Lewy body dementia is an umbrella term, and it covers two processes, two brain conditions that cause problems with a protein called alpha-synuclein. So we describe these as two synucleinopathies, dementia with Lewy bodies and Parkinson's disease dementia. And there are a lot of arguments about, is this all the same thing? Is it a spectrum? Are they two separate things? It's really a question of which came first, the chicken or the egg. So here's what I mean. I hope you leave slightly less confused. So here's my chicken and egg. So I want you to think about Parkinsonism, by which I mean slowness of movement, or our fancy term is bradykinesia. This is when someone comes to the office and we check their taps and their claps and their jazz hands and the whole thing. We're looking for movements that are slower than we expect them to be, and that they decrement. They kind of get smaller as they go, almost if you can imagine someone's got a resistance band slowly pulling tighter. And so from one tap to the next, they might get smaller or more broken up. That bradykinesia, that slowness of movement that gets smaller as it goes, that's kind of our hallmark of Parkinsonism. So if someone has that slowness and at least one of these other three, stiffness or rigidity of the muscles, a tremor, or changes in balance or posture, we say that they have Parkinsonism, okay? Of which Parkinson's disease is one kind, the most common kind. So for the purposes of this very tortured analogy, Parkinsonism is our chicken, okay? And then there's the question of dementia, right? We're going to use the D word. So people hear dementia and they think Alzheimer's. It's kind of how we hear Kleenex, right? And we think that applies to everything, right? All tissues are Kleenex. They're not actually, right? It's the same idea as headache and migraine. A lot of people hear headache and they might automatically assume migraine, but there are actually lots of different kinds of headache out there, just like there are different kinds of dementia out there. So dementia really means a change in a person's memory or thinking that is significant enough that it's affecting their daily activities. And so Alzheimer's has to do a lot with short-term memory. The person is repeating themselves in conversation. They're slowly kind of losing their memory of what happened in their life. They may lose recognition of the people around them, their family members. That is not this, okay? What I'm talking about is a group of symptoms where a person has changes in their attention, their concentration, their ability to make decisions the way that they used to, their multitasking, their visual-spatial processing, so depth perception, being in the middle lane on the highway and thinking that the car that's actually, 2 lanes over is right next to them. There are also these changes in alertness that we call cognitive fluctuations. And this is when a person could be totally spot on, really sharp, giving a presentation, doing whatever they usually do, their normal self. And 5 minutes later, they, or more likely their loved ones, can almost see the fog descend, the curtain descend. They're conscious, they're still talking, but the flow of ideas might be a little bit more halting. Their language might be harder to find the words that they want. They're just a little bit out of it. And it comes and goes. It could be minutes, it could be hours, and it's not predictable. So cognitive fluctuations, changes in attention, concentration, visual spatial, decision-making, and then changes in a person's kind of reality perception where they can have recurrent hallucinations, often seeing something that's not there. So that cluster of symptoms is a different form of dementia. And we're going to think about this as our egg. Okay? Still with me. So for most people, when we're talking about this kind of thing, they develop Parkinsonism first, and they are diagnosed with Parkinson's disease. And years go by, often 10, 15, 20 years. And then they may develop that form of dementia. These cognitive changes may occur. And when that happens, Parkinsonism first, time, dementia, we say that person has Parkinson's disease dementia. However, not everyone read that textbook. There are some folks where the dementia comes first. And then at some point down the line, someone notices that they're shuffling as they're walking, or now they've got a little bit of a tremor, or they start acting out their dreams during sleep. They develop the Parkinsonism later. Or everything comes together. Within a year of each other, we're seeing cognitive changes and the Parkinsonism movement changes. If we're in this group, we say that person has dementia with Lewy bodies. However, if you are in this crowd, if you've got the chicken and the egg together, regardless of which one came first or if they showed up at the same time, we say that you are under the Lewy body dementia umbrella. Jori, aren't those just the same words here, rearranged in a different order over there, and you're telling me that those are different things? Yes, kind of. I didn't come up with this system, okay? But this is where we are. People are trying to make better sense of this, okay? But someone with Parkinson's who goes on to develop these cognitive changes, if someone is told you have Lewy body dementia, that is not a new, different diagnosis. Any more than if someone with Parkinson's has constipation, we don't say, you now have a separate issue, right? This is part of it. Does everyone get this? No, just like not everyone with Parkinson's is constipated, but it's common enough that we want to talk about it so that you recognize and kind of know this is part of it. It should be part of the conversation with your healthcare team. I think for the sake of time, I'm going to skip over what makes a dementia with Lewy body diagnosis, because I just told you that. But I want to talk about a scary thing before I talk about what we're doing to fix it. And that is what we know as time goes on and what I get calls about every Friday afternoon is I just want to let you know that so-and-so is in the hospital, right? And so what are the triggers for hospitalization? And unfortunately, these are often the same things that are listed as the causes of death in people with Parkinson's or with Lewy body dementia. And here's what they are: falls, urinary issues. Urinary tract infections are the bane of our existence. Dehydration, metabolic changes, meaning dehydration and low sodium or potassium is off. And then neuropsychiatric issues like the hallucinations that can come along with those changes in memory of thinking. Delusions where a person is paranoid or they think that their loved one is actually an imposter version of their loved one. That's not the real Bob. When is the real Bob coming home? Or they say, I want to go home, even when they're home. And you wonder, do they mean childhood home? Are they talking about someplace else? But it's because that visual-spatial change that's going on causes whatever is in front of them, whoever is in front of them, usually the person or the place that they are closest to seem almost exactly right, but not quite right. Their brain is telling them something is off, and that can cause a lot of agitation and aggression. So these are big causes of hospitalization, but also caregiver strain. Caregiver strain on its own, even when in scientific studies we control for all the other things. We say two people with Parkinson's who've got just as significant of symptoms, but one has a caregiver who is just at the end of their rope, more so than the other. That person with Parkinson's whose caregiver is at the end of their rope, they are much more likely to wind up in a hospital than the other person, pound for pound. And what we also know is that once someone with Parkinson's or Lewy body dementia is admitted to the hospital, they are going to stay for longer. They're more likely to have complications in the hospital, and they're more likely to be discharged to a nursing home rather than back home. Why? It's not because the healthcare system is trying to harm people with Parkinson's in the hospital, even though I know it can sometimes feel like that. It is that our inpatient colleagues just do not understand. They don't have the training in Parkinson's or Lewy body. They understand that if a medicine is given 3 times a day, it's given 3 times a day. So maybe that's 7 a.m. and then 2 p.m. and then, midnight. It doesn't really matter if it's a blood pressure medicine, but it matters in Parkinson's, and that's not how people understand things on the inpatient side. So things get screwed up commonly, and this can lead to problems. So my team, I kind of describe my research as this is so far from rocket science. This is not even low-hanging fruit. This is wandering through the orchard and picking up the apple that just fell off the tree and going, this looks very nice and fine. Why don't we try this one? Our hypothesis is that if these are the reasons why people with Parkinson's and Lewy body wind up in the hospital, a lot of these things are preventable or could be managed at home, especially if we recognize them early. A lot of falls could be prevented. UTIs, if we catch a urinary tract infection or a UTI on day 1 rather than day 5, that's the difference between someone being able to stay at home and get an antibiotic versus someone being in the intensive care unit requiring IV. But doing that requires an educated, engaged, observant caregiver, care partner, carer, champion. So what do we know about Parkinson's and Lewy body care partners? Okay. And if you do not know who this character is, let me strongly recommend watching the Disney movie Encanto. Grab whatever child, grandchild you have around if you need an excuse, but you shouldn't need one. I really feel it's a great movie, but I feel like the Louisa character who has superhuman strength and literally carries the world on her shoulders, she has big Parkinson's care partner energy. Okay. So what we know, and I wish we knew more, but here's some data. About 83% of community dwelling people with Parkinson's or Lewy body dementia rely on unpaid caregiving from family members. And if we add that all up, it adds up to 18.5 billion with a B, billion hours of care annually. And if we paid for that time and effort, which we don't. But if we did, that would be over 232 billion with a B dollars. We know that our care partners, even early in Parkinson's, have a nearly twofold loss of their own direct income, often because we need to take a little bit of time off of work to go get someone to physical therapy. We need to go to a doctor's appointment. Oh, something came up. We need to run to the emergency room. We need to cancel something. It has an impact even in early Parkinson's. And as time goes on, especially as we get into later stages, what we know is that Parkinson's and Lewy body family care partners have higher rates of strain, of caregiver burden, of their own depression, compared to care partners of people with Alzheimer's and related dementia. And I will tell you that I have been privileged enough to work not only alongside Lewy body and Parkinson's care partners in my clinic, but to have care partners as part of my research team for years. And so I get to write papers and have co-authors who are care partners. And anytime you write a paper in academic medicine, you submit it and you get reviews back. And there's always reviewer two. And I always picture reviewer two as a very crotchety person. They're reviewing at 2 a.m. They are unhappy. Maybe they're going through stuff in their relationship and they find everything wrong. And so we submitted a paper about Lewy body care partners and Parkinson's care partners and how they just have things worse. And they said, why? Why do you think that they're any different than Alzheimer's care partners? And I just forwarded that review on to my care partner co-authors and let them have at it. And they had words. The words did not have many more than 4 letters in them, but they had words. And when we tried to translate that, it's because there is a combined deterioration, not just in cognitive symptoms, but there are movement symptoms, there are cognitive symptoms, there are neuropsychiatric symptoms like depression, anxiety, apathy. Oh my God, the apathy, hallucinations, delusions, and then the non-motor things, the urinary issues, the constipation, the temperature dysregulation, the blood pressure dysregulation, and none of it is coordinated with its the other stuff, right? You could have a great constipation day, but you could have a bad urinary day. Why don't they all hang together so you have one bad day and then you could have a good time? It doesn't work like that, right? And so you can't know from one day to the next, one moment to the next necessarily, what exactly is going to go on. And that takes a toll, not only on the person living with the diagnosis, but on the care partner. And so in response to that reviewer two, I give you this terrible, ugly table. But what this is that our care partners said, well, why don't we just ask people what medical problems they have? And let's see how that compares. So we asked in a survey that we were doing in another study, we had 182 care partners who were actively caring for a loved one. And we gave them a survey that just has a list of different medical problems and said, do you have this? And we compared that to age-matched data, basically what data is out there about the rate of back pain in different age groups of people. And so what this shows is this lighter gray column over here. This is the percentage of Lewy body Parkinson's care partners who have that issue, all comers among 182. So 38.5% had high blood pressure. But when we look at the dark gray, this is broken up by the different age groups. And what this tells us is that, yes, even though high blood pressure is more common as people get older, if it's in dark gray, it means that our care partners in that age group had statistically higher rates of that problem than other people their age. So it's not just the fact that we have a lot of care partners in their 60s and 70s and 80s. That doesn't explain why their blood pressure is higher. That doesn't explain the rates of depression that we see. It doesn't explain the rates of back pain that we see. Age alone is not enough to explain this. It has to do with being a care partner. So what else do we know? I told you that caregiver strain independently increases the risk of a person being hospitalized. It also increases the risk of a person being placed in a nursing facility. And unfortunately, for all too long, there were no effective Parkinson's or Lewy body care partner interventions. That's changing. What we did know when we started off this research program was that even among the interventions that have been studied scientifically and found to be helpful, they are costly and they're not very sustainable. So there are some dementia interventions for care partners of folks with dementia, and usually what that means is 99% have Alzheimer's. And this means you sign up for a program, and for 12 weeks, you talk with a nurse on the phone multiple times a week. They call you, they go through questionnaires, they do all kinds of stuff, and they check in, and you go to visits and you do all kinds of things. And maybe you have the time for that, but most people do not. And it's a tremendous amount of funding to require a program like that in perpetuity. And no one has that kind of funding before, and we certainly don't have it now. So many people come to clinic and they say, okay, Dr. Fleischer, I can't, I'm doing everything that I can, and my loved one is still falling, or this is happening. You can send someone, right? And I feel like every day it is my job to break people's hearts and say, no, insurance does not cover paid caregiving. No, even hospice does not cover paid caregiving. It is out of pocket for the majority of people. And it is extremely expensive. So depending on the cost of living where you are, figure around $30 an hour. But in some areas, it is much higher than that. And even if you have that money to spend, which most people do not, it is still hard to find a care partner, a caregiver, because they're in high demand, they're in low supply. That was true before COVID. They had high turnover rates before COVID, and it is absolutely worse now, which is to say nothing of the fact that many paid caregivers are women, minority women, and they may be immigrant women. And so this is going to be even worse now, foreseeable future. And there's minimal to no training of caregivers in dementia, in Parkinson's, or in end-of-life care. So this is not a sustainable option for most people. And so for way too long, I told people, I don't know. The cavalry is not coming. We have to come up with something better. And so, what do we come up with? So, I was lucky enough when I came out of fellowship, training to be a movement disorder doc, that I wound up unexpectedly. My husband's also in medicine. We thought we were coming back to the Midwest, and he unexpectedly matched in New York. And so, having no knowledge of New York, we wound up there. And I had a wonderful mentor who said, I am losing track of my sweethearts, patients who he had followed with Parkinson's for years and years, who then, as the disease progresses, it becomes harder and harder to get to the clinic. And so there are missed appointments, or there are phone calls from the care partner saying, we just can't get there. They were just hospitalized. This just happened. And people were falling out of the loop of care, even though they were, connected to a movement disorder specialist. And so my boss said, you seem like you're interested in warm, fuzzy stuff. Go see if you can connect with them. And so we kind of thought about this almost as the equivalent of the very first stage of a clinical drug trial is what's called target engagement, proof of concept. Can this drug, this molecule, cross the blood-brain barrier and get to where it's supposed to go? We don't even know if it's going to do anything, but like, can it just get there? So we thought of this as a phase 0 trial. Can we cross the clinic to home barrier and meet people where they are folks with the most advanced Parkinson's and assorted disorders. So we knew that this didn't just take a physician. And I will tell you that the MD role was the least important. I did the least because I had a nurse and a social worker with me. And so I did everything that I would do in a clinic visit. I tapped and I clapped and I watched people walk. And you see so much more about their walking when they're walking at home versus when someone is showing off in clinic for us, which we know that they are showing off in clinic for us. But we went to the home always as a trio. And while I was sitting with the person with Parkinson's and doing their exam, my nurse and social worker were doing the meat of the work, which was my nurse would ask about falls, ask about the various things. We would check blood pressure, real sitting down, standing up, seeing if someone drops. But then we would go to the meds. And as opposed to what we do in the clinic way too much, was just to say, are you still taking everything the way that you were before? Yes? Great. Check off the box and say, we have reconciled the medications. Everything is perfect. My nurse would say, take me to the meds. Can I see how you organize everything? And in some homes, that was the beautifully organized, multi-segmented tackle box with the alarms and everything. And in more homes than you would imagine, it is a gallon Ziploc bag into which all of the pill boxes have been dumped. And when we look up at the clock and go, oh, it's 2 o'clock, it's time to take the 2 o'clock meds, someone reaches in and looks for the little white pill and the little yellow pill. Or it's a person living on their own with two identical paper plates sitting on the dining room table. One that has the bottles of what she's supposed to take, one that has the bottles of everything that's been discontinued, or the refills, or the things that she's allergic to or has had a side effect to, but that she's paranoid about and doesn't want to get rid of. And they're sitting right next to each other on identical plates. So being there and seeing what's actually happening was profoundly eye-opening. And while that was happening, my social worker was sitting with the care partner, if there was one, and saying, what services are you receiving? What would be helpful? How are you paying for food? Because my nurse would say, would it be okay if I look around the house to look at safety issues, not just snooping around, but looking for signs of falls, looking for that throw rug that looks like someone keeps tripping over it. And with permission, opening the pantry and the fridge. Because for all of the time that Uncle Google spends thinking about protein and levodopa interactions, what's even more powerful is whether or not someone has access to protein, whether they have food in their house. So all together, we did all the stuff, came together as a trio with the person and their care partner as the key members of the team and said, here's what we're seeing. Here's what we think we can work on. How does all of this sound? Are you on board with the following? And we placed referrals and we did all kinds of things. And what we found was that in every other study of Parkinson's, as time goes on, Parkinson's function goes down and quality of life follows right alongside it. And I will tell you that I had colleagues who told me, Jori, you probably won't even see that because if folks are that bad, they probably can't get worse. These are movement disorders specialized neurologists with a progressive neurodegenerative condition who, because it is so hard for people to get to us, have not seen people with advancing disease. And so they have been led to the conclusion that if they're not seeing them, they must be stable. And so we found not only were people indeed getting worse, but with home visits, in every other study, quality of life followed that same slope. Quality of life stayed the same in our folks who had home visits over the course of a year. What didn't stay the same was caregiver strain. And in every other study, caregiver strain gets worse. And we found even with home visits, caregiver strain was still getting worse. So that told us we're onto something with this home visit idea, but we need more for our care partners. And it was small. There were small numbers of care partners, but we knew that home visits alone wouldn't be enough. And so we wondered, could connecting caregivers together one-on-one ease the journey in the isolation? Because we don't need to reinvent the wheel of support groups, right? You're all here or you're watching, right? So I don't need to tell you how important support groups are. They are pivotal. But some people may never join a support group. Or for some people, the support group is not enough, or they don't feel comfortable enough to ask that one question that's the most important question to them. But what has been studied also is peer mentoring, meaning one-on-one connection of someone going through a journey to someone else who's going through that journey. And initially, this had been looked at in care partners to people with Alzheimer's disease. And the quantitative data, the actual numbers of it, didn't look all that compelling. But thankfully, they did some interviews. They got qualitative data, actual words of actual people saying, here's what this did for me. And what it showed was that this was profoundly meaningful, not just for the mentee, but also for the mentor. And so since that time, this idea of peer mentoring has taken off like wildfire. Almost every college in the US has peer mentoring, where if you're an incoming freshman, they pair you with someone, an upperclassman, to tell you, sit here, don't sit here, take this session of calculus, don't take that one, that professor's terrible, right? Someone who is close enough in the journey, but has some experience and can help make it better. And in healthcare, peer mentoring has been shown to improve outcomes in trauma survivors, in cardiac survivors, and the group that I cannot imagine having any more reason to have experience and then run in the opposite direction and never, ever, ever try to touch that again They have shown in studies that bereaved parents who have lost a child to cancer will willingly serve as a peer mentor to other parents who are going through it. And I cannot imagine this. And if it works in that population, that was the thing. That was the clincher that told us we need to look at this in Parkinson's. So we did. So fast forward, I moved from New York to Chicago. We got funding from the National Institutes of Health, thank you, to test this idea of the home visits. We made it a little bit telemedicine friendly. This was before COVID even. And when people were getting a year of home visits, we nested within there this idea of peer mentoring for our care partners for about 16 weeks. So we showed up, we met someone, we did home visit 1, we checked in with them, we followed up with them about 16 weeks later, we went for visit 2 and we said, how are things? We did all the same stuff that we did in New York. And we said, by the way, as we left and we left them with their plan, so-and-so is going to call you sometime this week. They are a care partner for a loved one with Parkinson's or related disorder. They've gone through training with us. They're vetted. Just talk to them. That's it. We're not even telling you what to talk about. We just hope that it'll be helpful. And I was lucky enough, I have been profoundly lucky to have social workers with me at every step along the way. And so our social worker, Jeanette Lee, created a very quick handbook to give to our mentors who we trained in that first iteration, just to help them along the way. And it was a lot of stuff that we talk about in clinic and some tip sheets, what to do for constipation, stuff like that. And what we found was that it worked. And when we did our home visits over the course of a year, and we actually had a control group, which was drawn from the Parkinson's Foundation, they have a registry. And so we said, give us anyone who's similar to our folks who we recruited. And they said, I got bad news. We don't actually have folks who have continuous data who are the same severity of Parkinson's as in your study. So we said, okay, fine, give us anyone who's got data from when they are a Hoehn-Yahr stage 3, which just means that they're starting to have falls. So if they had 2 visits where they were a Hoehn-Yahr stage 3, we said, we'll take that data and we'll compare them to our people. And so our control group, it's apples to oranges. The control group is younger by about 10 years. They are healthier. Their Parkinson's is not nearly as severe. They're less likely to have dementia, all kinds of stuff. But what we found was that over the course of a year of getting home visits, just like in every other study, our control group got worse. Quality of life got worse. But our home visit folks, even though they were much more advanced, their overall quality of life stayed the same, and certain domains of quality of life actually got better because we were paying attention to pain. We were paying attention to communication and to stigma and doing something about it. And it turns out there is no point in Parkinson's at which we cannot help someone. I will say it again for those in the back. There is no point in the journey of Parkinson's where there is nothing that we can do. There is always something that we can do. And this study helped us prove it. And when we added in peer mentoring, what we found was that in the control group who didn't get it, whose loved ones were healthier, their caregiver strain worsened over a year. But those caregivers who had home visits and peer mentoring, they stayed the same. So now we were onto something. And so we took this and we moved this to the next phase. COVID was happening and we said, okay, well, home visits are over for right now. What else can we do? And so we decided to test this idea of the peer mentoring just on its own. And for reasons that I cannot fully explain, the National Institutes of Health has a different pot of money that covers Alzheimer's and related disorders than covers Parkinson's. So if you are applying for a grant and it falls in the Alzheimer's and related disorders zone, you have a much better chance of being funded. And for reasons that should be very confusing, Lewy body dementia, the umbrella term, falls under that Alzheimer's disease and related disorders. But Parkinson's alone does not, even though they're under the same umbrella. Okay, so we said, we will work on this grant and we will make it a Lewy body inclusive grant with the hope that that would increase the chance that it would actually happen and be funded and then would be able to be adapted for everybody with Parkinson's. And if you're making a grant, you're supposed to come up with a catchy acronym. So Full
Mm.
disclosure, I grew up in a family with a lot of neurologic disease. That's why I went into neurology. And I was lucky enough that my grandparents, who raised my aunt with severe neurologic illness, taught me the word persevere when I was 4 years old. This is part of the family legend. And the dictionary definition of persevere is to continue in a course of action, even in the face of difficulty or with little or no prospect of success. And so if you want to get a grant, usually you have to come up with a catchy acronym and you have to squeeze words together and everyone goes, really? That's what they did? But if you look at the underline, you can come up with peer mentor support and caregiver education in Lewy body dementia and sort of spell out persevere. So we titled this next study Learning to Persevere, and we did focus groups of the caregivers and the mentors in that study I just told you about, and then caregivers who hadn't been part of it at all. And we said, if you were to do this, what would you want to learn about? What would be helpful to know? Maybe there's enough out there online. Maybe you're getting enough that you don't need a handbook. You don't need a curriculum. You just need to talk with someone. And oh, did they have thoughts? And we made it entirely virtual. We partnered with Parkinson's Foundation and the Lewy Body Dementia Association to send information out online. And we wound up training 36 new mentors from all across the United States. What did training look like? Totally online, on Zoom, just like this. We did sort of a primer because we know that if you've met one person with Parkinson's or one person with Lewy body, you've met that one person. And so your caregiving journey may be completely different from someone else's, and that is okay. It's not only okay, it's wonderful, but we also want to make sure that you kind of have a sense of all the different symptoms so that you can support someone else. But we also talked about active listening and safety and role playing and all kinds of stuff so that our mentors felt comfortable and supported. And then, even though there are other studies of peer mentoring that said it doesn't matter who you match with who, if they've been on the same journey, it's all the same. That was not the sense that we got when we did our focus groups, because adult child caregivers said, I'd really prefer to be matched with someone who's cared for a parent. It's just different than someone who's cared for a spouse or significant other, and vice versa. And we hear that. And so we asked people, what are your preferences for being matched? How important is age, gender, role, all of this stuff to you? And we're not Tinder, but we tried our best to match people up according to their preferences. And we wanted to make sure that we were supporting our mentors. We recognized that this could be really triggering. And so we set up monthly mentor-only Zoom conferences, basically a support group for the supporters, where they could come and say, here's what's really challenging, or I'm struggling with this with my mentee. Does anyone have any ideas? And when I say that we ask them, what do you want to learn about? This. So we wound up creating, at first, what was a 16-week curriculum. And it became really apparent that while there are symptom topics, what we called LBD mastery topics, there's also all of the other social support. There's the how to be a care partner, how to normalize all of the emotions. Oh my God, am I the only one that gets angry? Am I the only one that yells at my loved one and then feels terrible? I feel such guilt, but I can't talk about it because Susie seems to act like everything is fine. And they talk about how they go out and they do all these things and I can't go out, right? And so all of this stuff had to be put in there. And all of it came from care partners telling us, add this, more of this. You need to talk about this. So we put it in there. And we paired people up and we said, okay, next week is week one. Here's the curriculum. The curriculum wound up being a book that we sent out to people with conversation starters for every week because you don't know the person who's calling you on the other end of the line. Who is this rando? And I don't know how I'm going to start a conversation with them. So we gave that to people. And we said, just talk. We hope that you'll talk once a week for these 16 weeks. We know that life happens. We did not tell people how long to talk. And what we found was that despite active caregiving demands or bereavement, care partners prioritize this. We had 30 pairs. They all stuck with it. It was over 400 calls. It was 15 calls on average, and they talked for an average of 45 minutes. Some of the pairs talked for 2 hours a week. 100% of people recommended it. And we asked people, would you do this again? Recognizing that this could be triggering, this could be really emotional. We had care partners who had lost their loved ones and were bereaved. And 90% of the mentors said, absolutely, keep me on your list. I will do this again. And when we asked the mentees who were within the first couple of years of their loved one having cognitive change, 40% said, I'd like to go around and do this again as a mentee with another mentor. I'd like to get more perspective. 10% were like, I'm good. Leave me alone for right now. But 50% said, I'm ready to pay this forward. I'm ready to be a mentor to someone else now. And so maybe as we've been waiting for the cavalry that hasn't been coming for far too long, maybe we haven't realized that the cavalry is all of us, is the lived wisdom that far too many care partners don't realize how much they know and how wise they are and how much that can benefit everyone else around them. Because we also found that not only did our mentors start off knowing a lot, but even the mentors improved in their Lewy body knowledge, as did our mentees. And the mentees improved their attitudes and their confidence and their skills caring for a person living with Lewy and Parkinson's. And there was even a trend towards the care partners improving their own depression. So even though the NIH has not historically funded a ton of care partner research, and even though the NIH has not historically funded a ton of peer-driven research or Lewy body research, which gets funded at 1/8 the level of Alzheimer's, the NIH funded the next step, which is going on now, which is still a pinch me moment every single day. And it's the first thing that I check in the morning to make sure that I am still funded, which is the Persevere study. So first we learned to persevere and now we're persevering. And so this is open now. And what this is, here is our little QR code. It takes you right to the website if you're interested. Here is our map. So Maryland, you're looking good, but you could look bluer, which means we have more people. So the study is going on now. We've changed the curriculum. We've condensed it into 12 weeks because we heard that from all of our folks. But basically, it is a national, entirely virtual, randomized controlled trial of this intervention for care partners living with a loved one with Parkinson's, with any cognitive change, Parkinson's with dementia, Parkinson's with hallucinations, or dementia with Lewy bodies, or Lewy body dementia. If you are anywhere under that umbrella, regardless of what label has been stuck, you are welcome. And so this is a 12-week curriculum with resources and activities and about 6 months of follow-up. We are recruiting experienced care partners to serve as our peer mentors. We are at about 150 of our 180 goal, which is amazing. And then we are recruiting care partners who are within the first 3 years of their loved one having cognitive changes. So that means a person could have Parkinson's for 10 years, but has only just started to have cognitive change. That counts. And the care partners, that group of folks, are randomly assigned half and half, but our control group is not a true control group. Everyone gets something. So half get the full curriculum and matched with a mentor, but the other half, and we have had really good retention of our control group because we've built a curriculum specifically for them. So no one gets nothing, everyone gets something. All participation is virtual. All of the surveys are completed online. And so this is what we have going on now, and we are tremendously hopeful that if this works the way that it looks like it may work, this is something that we would want to be available to everyone once the study is over. So if you are interested, it is open to you now. And because I have these amazing care partners who are part of the study and say, Jori, do this, don't do that, you should be thinking about this. They said, do you know that people are getting their information about Parkinson's on TikTok? And I said, oh dear God, I thought it was just recipes and dancing. And they said, and Instagram? And I went, no, please no. And so we are now on TikTok and Instagram, just with daily tips and tricks and life hacks and things that we have learned from care partners and people living with these conditions. So if you're interested, this is just what it looks like. We had to actually put in one of these annoying I'm not a robot buttons because we were getting lots of spam and robots trying to join the study. So apologies for having to click another button, but it will bring you to a website that talks more about the study if you're interested. We even have testimonials from care partners who've been part of it. So you don't have to take my word for it. And then it leads you to a survey. And if you qualify, you will hear from one of my two awesome, awesome coordinators. We have a social worker in the background fielding any questions. We screen people for depression or bereavement. If you score high on those things, you will get a call from Sarah, my amazing social worker, to check in with you and offer resources. This slide is now out of date because, as I said, we are aiming for about 180 mentors, and we are at about 150, which is remarkable. And we are over the 300 mark towards our 502 of caregivers in the study. We have also been trying really hard to reach care partners who have not historically been represented. And in the Parkinson's and Lewy body world, that means male care partners, that means adult child care partners, that means care partners of color, and those who live in rural areas. So does this mean that we are not open to female care partners, white care partners, people in metropolitan areas? Absolutely not. Of course we are open. But we specifically want to make sure that the study includes everyone who's a care partner with Lewy body and Parkinson's. So we have been trying to hit all 50 states and all US territories. So if you know people living with Parkinson's or Lewy body in Guam or Puerto Rico, we are ready for them. We have resources ready for them. We just need to find them. And we have been incredibly lucky that all of these different organizations have been sharing information, but I just want to point you to other is support groups all around the country. So the highest yield, and this kind of proves the hypothesis, is where are people with Parkinson's and Lewy body learning information that they trust? It's from each other. It's from support groups. So thank you to Judy and to everyone who hosts support groups, who keeps them running, all of these things, because this is where people get their information about all of the things, and where people have heard information about studies. So with that, oh, we just got all the logos. Here's that info again about Persevere. Check us out if you are on TikTok or Instagram. They are very goofy, somewhat embarrassing videos that my children are really entertained by. But we do, oh, I think that it's probably not going to work, but stuff about dehydration, stuff about cups that work, you can't tip your head back, all kinds of these different things. So check those out. But I hope what we've gained is recognizing that Lewy body dementia, super confusing term, is common. And one of my mentors described it as possibly the biggest disease you've never heard of, because people with Parkinson's often don't realize that this may apply to them. It's misdiagnosed, it's all over the place, and care partners often don't have the information they need. There are identifiable and potentially preventable or manageable causes of hospitalization for this population, which maybe could be detected by trained, empowered care partners. And our care partners have higher strain and burden than care partners for individuals with Alzheimer's. And despite that, it is potentially modifiable with peer mentor-led educational intervention. Despite this high strain and burden, our care partners, amazingly, will willingly share their lived experience and train as mentors to newer care partners, who then improve their own knowledge and attitudes and want to serve as future caregiver peer mentors, creating a pipeline that we've never had before and we have so desperately needed. So with that, I want to thank you for your attention. I want to acknowledge the amazing teams that I get to work with every day, my clinic team, my research teams, my mentors and advisors, my mentees who challenge me to always think about better things. We have unbelievably generous support from all of these foundations and from patients and care partners. My kids who encourage me to always look to tomorrow and what we make better for people. And finally, these are my grandparents. They are the ones who showed me what it is to be a care partner to a loved one with neurologic disease. They taught me the word persevere. They raised me to be the person that I am. And when I went into movement disorders, I did it because there was something about Parkinson's that called to me and told me that these were my people, even though we did not have movement disorders in my family. And fast forward to being a movement disorders neurologist, and both of my grandparents were ultimately diagnosed with Parkinson's and Lewy body dementia, respectively. So I have seen this on the doctor side, but I've also seen this far more than I would ever want on the family side. And so I see all of you living with this and caring for loved ones with this. I see how hard it is. I see how rewarding it is. And I just thank you for the opportunity to share this with you. So with that, I will stop sharing, and I'm sorry to talk too much, but I'm happy to answer any
Okay,
questions.
that was really wonderful, wonderful. And I've got lots of other questions for you. So you're going to have to give me your email or
Of
something.
course,
But for
absolutely.
right now, I'm going to start with we've got 10 questions that were pre-submitted. And
Amazing.
for those of you who are still on, which most of you are, feel free to, if you have something else to ask, chat or raise your hand. So the first question is, I feel horrible guilt each time I get frustrated with my husband. I do yoga. I get up early, no news, no phone, and I watch the sunrise as I crochet. These definitely help, but just short term. I feel overwhelmed, and every blip in my day adds to my feelings of not doing or being enough.
I feel like I have read that question, heard that comment hundreds and hundreds of times. So, number one, you are not alone. You are not alone. You are not alone. You are not alone. You are doing an amazing job, truly. And you have incorporated all of the things, right? You're appreciating, you're being mindful, you're being grateful, you're doing all of the things, you're doing yoga, you're crocheting, right? And it is this disease, it is this condition. So I think to whatever extent it's possible to normalize that there is nothing wrong with you, there is nothing wrong with your loved one that is making you feel this way or react this way. It is the disease. It is not a reflection on your relationship, on your caregiving, any of it. It is that this is a tremendously frustrating condition to live with, to try to navigate, to care for. Keep doing all of those things and recognize that you're not alone and reach out for the additional help that you need. And maybe that's talking in a support group. Maybe that's talking one-on-one with someone, whether it's Persevere or it's someone else, whether it's your neighbor over the fence, whoever it is. Right? Maybe it's someone reaching out to, if you're part of a faith community, reaching out to someone in your house of worship, to a clergy member, that can be great. If that's not you, don't, that's not you, right? Whoever that is, finding a therapist. Psychology Today has a wonderful website where you can basically, it's like Tinder for a therapist. You can say, I have this insurance. I want a woman. I want a man. I want it virtual. I want it not virtual. Here's who I want. You can put in caregiving as a specialty for a therapist that you want. There are caregivers who just specialize in talking with caregivers. So I think you're doing all of the right things, and this is hard.
Okay, next question. And thank you for the person who just said wonderful presentation. Thank you.
Oh, thank you.
How do I get my husband to take his medicine on time when the alarm on his phone goes off and to drink enough water? I feel like Sisyphus pushing that rock uphill every day, trying to get him to do everyday things that he does need to do.
Also, you are not alone. I do not know what it is about Parkinson's and Lewy body, but our folks do not drink water. So that's number one. We spend so much time in our clinic pausing and having the alarm go off and the loved one get the water bottle and the thing and do all the stuff and watch the person take the teeniest, tiniest sip of water. So number one, doesn't always have to be water. Okay. I work with a dietitian in my clinic and she's amazing. And she will remind everyone, honest to God, if you need to take that pill with soda and that helps you get some fluid in, so be it. Everything counts. It could be juice, it could be milk, it could be soup. It doesn't matter. It could be a nutritional shake, ensure whatever. It counts as fluid. Fruit, especially now in the summer, if they take a sip of water, they take their pills, and then they have a nectarine, it's 90+% water. That actually counts. Fruit, she thinks that she describes as like delayed release water because of the fiber and everything else. Um, Other strategies, they're really, really hard to get people to take their meds on time. Number one, I would talk with the healthcare provider to see, are there any meds that we no longer need? Because as time goes on, there's a lot of set it and forget it in medicine. And sometimes people acquire 27 supplements and vitamins and minerals and nutritional things and all kinds of stuff, plus the cholesterol pill and the aspirin and the whatever and the whatever. Sometimes we can pare back on some of that so that if we have to struggle to remember pills, We have fewer times during the day to interrupt our schedule. And we're really focusing on taking the stuff that really, really matters. Then it sounds like you're already doing pill alarms or phone alarms. What we find often happens, and this I've seen this in my own house, is the phone alarm goes off and we hit snooze because we're in the middle of something. And we're going to go in the kitchen and we're going to get the pills in a minute, but then that never happens because we turned off the alarm, right? So there are actually pill containers. You can look on Amazon or wherever. There are vibrating, alarming pill boxes into which, like, the front of it looks like a pill box. The back of it, you can set multiple alarms, which means that the thing that's vibrating or ringing actually has the pills in it. So you've got them all together. There actually are some water bottles out there where there's a water bottle and the bottom of the water bottle unscrews and it can contain multiple segments of pills. It's like a little pill compartment stuck to the bottom. So use technology in your favor for this kind of thing. And there's no one right answer.
What can be done about anxiety and delusions in people with PD? We have a small assisted living facility, and one individual has Parkinson's. We have a psychiatric nurse who comes in and works on adjusting the medications. She also sees a physician every now and then. Thank you.
That's a great question. I think it's, if it's at all possible, seeing a psychiatrist or seeing a movement disorder specialist may be beneficial, even if it's a one-off consultation to offer sort of if then, because the management, especially when it's not just anxiety, not just depression, and not just delusions, but it's some of all of the above. When we've ordered from all of the columns, choosing the right medication or medication combination is exceptionally difficult and really requires someone who this is all that they do. So just as kind of general guidelines, in anxiety, the SSRIs or selective serotonin reuptake inhibitors. So these are things like Lexapro, escitalopram, sertraline. These are our first line. Even though we think of those as antidepressants, those are actually our most powerful, safest, most effective medications for treating anxiety. We don't want to use things like Xanax, Valium, sort of the pop a quick pill if someone is really anxious, because that's like playing whack-a-mole. It doesn't unplug the game, doesn't take the moles away. The anxiety is just going to keep popping up. And those meds can be sedating and they increase a person's fall risk. So we really want a regimen that helps make sure that they're sleeping well at night, not during the day, and that helps control the anxiety. And better, something that slowly changes their brain chemistry back to what it used to be, rather than just trying to smack the anxiety down when it arises.
Okay, next question. My husband started amantadine last week to help with his dyskinesia. As forewarned, he is having hallucinations, more trouble walking, and much more confusion. What drugs do you suggest? Of course, we will check with a neurologist at Rush, but we wondered about alternatives.
Oh man, this call is coming from inside the house.
Sounds like it.
So, I will be honest that I, as someone who focuses more on later stages and PD dementia and dementia with Lewy bodies, I don't love amantadine for all of those reasons that the person just wrote in, is because while it can be very helpful for someone with dyskinesias and kind of allow you to keep the same level of levodopa, a sort of dopamine stimulation for mobility, without having to lower that, it very commonly can cause hallucinations and delusions and all kinds of other things. So, again, I cannot offer specific advice, not caring for that person, but definitely talk with their provider. So usually the best thing to do would be to take away the medicine that's causing the side effects, and then think about, once that's cleared up, if someone is having hallucinations, delusions, cognitive changes without the amantadine, then we can think about some of the medications that are out there. And often our go-to to start with are medications like donepezil or Aricept or rivastigmine or Exelon. And these are meds that were developed for people with Alzheimer's. And the common thinking is like, well, they don't really do anything. In the big clinical trials, people with Alzheimer's were given these drugs. They were either given the real deal or the placebo, the sugar pill. And they watched them over time. And everyone got worse over time. But the people who got the real deal got worse more slowly. And so what that told us is it's slowing down what the course would otherwise be. But that means that people come back to their doc and they say, this pill isn't doing anything. They're still getting worse. Even though on a microscopic level, I would think about it kind of like a vitamin, is it's doing something underneath, even if we don't see the obvious effects. Better with it than without it. But in people with Parkinson's and Lewy body, although we haven't had as big of trials, in the studies that we have, these drugs often seem to have that same effect where they're slowing down the otherwise progression we would expect. But there's a chunk of people where they seem to stabilize, at least for a period of time. And there's about 20 to 30% of people where they improve. Is it huge? Is it perfect? No. It's not the cure that we want, but it's something. And in people who are having not full-blown, huge, scary hallucinations, but hallucinations that are there and starting to be bothersome, often these medications, donepezil, Exelon, can take the edge off and help with those hallucinations before they get more out of control. So those are often the first things that I reach for.
When the person with Parkinson's is a controlling person, how do you actually know when they really need help? And can a caregiver do anything for the person with Parkinson's depression?
Oh, those are good questions.
I
How do
told you we
you
had some good ones tonight.
Those are amazing questions. Those are hardballs. So, how do you know? I think it's really difficult, right? And especially if the person is a private person, if they're kind of keeping their symptoms under wraps, it can be very, very difficult. One of the things that we see really often is someone who is very high functioning at baseline, maybe is, very intellectual. And what we see is that because the brain has an immense ability to compensate, a person can kind of fake it and trick you out for quite a long time. And it's sort of I don't know, I have this image of like the little duckling that's on the surface of the lake, and they look like they're just kind of cruising really gracefully, but underneath they are paddling like hell. And often that person who is very high functioning is doing okay until there's something that causes them to crash. It's a urinary tract infection, or they get COVID, or they get the flu, or they have a minor surgery or something. And then it seems like everything breaks loose. And it's basically because we've lost that compensation. We're kind of seeing what was there underneath. And I wish that it didn't take something like that. But if a person is kind of not letting their care partner in, often that's where trying to bring in extra help can be really useful. And that doesn't have to mean extra paid caregiving help, but it might be, so people will say no most easily to the people that they're closest to. So a spouse with Parkinson's is going to refuse help or is going to say no to going to PT, to doing the things that they're supposed to do, to taking their meds, to their spouse. But maybe if an adult child is part of the picture and calls twice a day, or calls once a day during the time where it's hardest to take the meds. And that's what the spouse says is, when they say, I wish that I could help more, call mom at 2 o'clock every day. Doesn't even have to be a long call. It could be a 2-minute call. Hey, how's it going? Do you mind taking your meds while we're on the phone together? And let me tell you what's going on over here. That's it. And it could be a 2-minute intervention, but maybe they respond to that where they won't respond to someone else. Maybe they respond to doing something with a neighbor or someone from the community, and they won't respond to that from the care partner. And how do we help with depression? Number one is recognizing, and this is part of Parkinson's. This is part of Lewy body. It is just as much a part of it as the slowness, the stiffness, the tremor. So I think for some people, there's the misconception that they should be able to just snap themselves out of it. Stop feeling sad, get up, pull yourself up from your bootstraps and just come on, right? We don't say that to anyone with a tremor. Like, have you ever looked at someone and gone, like, if you really just thought about it, you could stop shaking? We don't do that because it's a chemical change in their brain that's causing this. The exact same thing is true about depression and anxiety and apathy. So we have to build scaffolds around them. And that can be non-medication, that can be helping them to get to a therapist, normalizing that this is part of it, getting them resources, leaving out resources from the Parkinson's Foundation or Davis Finney or wherever you want to pull resources from. It just happens to show up and it's on the coffee table for them to look at if that's how they need to see it. And if not, demonstrating that if you are living with depression or mental health issues, take care of yourself. Show them what that looks like. I think that's the most helpful thing. And go with them to their healthcare provider visits and bring it up and let us be the bad guy. We can tackle it.
Can you discuss respite care and how does one qualify?
Oh, that's a great question. Okay, so I think what they mean is respite care, which is part of hospice care. So let's take a step back. Palliative care versus hospice care. Palliative care is a term. It is a specialty of medicine. People go do a fellowship in palliative care. And really what it means is interdisciplinary, multiple team members coming together to support complex symptom management and a whole person, not just a medical person, a whole person, everything that makes them them when they're dealing with a serious life-altering illness. That's palliative care. Hospice is a subset of palliative care. Hospice is an insurance benefit of Medicare or your private insurance. And a person qualifies for hospice if their treating healthcare provider thinks that this is the actual line. If I have a 50% certainty or higher that the person in front of me may be within the last 6 months of life, they qualify for hospice. That's a whole lot of if, then, maybes, and percentages. We do not have good prognostic guidelines in Parkinson's. We just don't. Many of us are working on it. But if a person qualifies for hospice, and most of the time that means home hospice, that means the person lives at home, they're still there with their care partner, they are in their comfortable setting, and it means that a team, usually a nurse, maybe once a week, a social worker, maybe once a week, comes, visits, helps provide the medications. The medications come through hospice. They provide supplies like incontinence supplies, a hospital bed, things like that. It also means they provide a 24/7 phone line so that if something changes at 3 a.m., you do not need to go to the emergency room and sit for 20 hours. You can call and say, here's what's going on. I'm worried. What do I do? Do we need to go in? Can we triage overnight? Someone maybe will come out in the morning and take a look, right? There's someone warm body on the end of that line who will answer, and that you have access to respite care as part of hospice, which means 5 days where the person who is admitted to hospice can be transferred to an inpatient hospice facility. And that may look like a unit in a hospital. So I'm at Rush. Rush has a hospice unit inside of the main hospital, but there are also hospice agencies that have freestanding hospice units. That's it. You go, you drive into, the little corporate village place, right? And there's a hospice building. And that is all that they do. Those nurses are angels who walk among us. That's all that they do. And so they will care for a loved one. And you can say, I need respite care because I need respite care. You do not need to give them an answer. You don't need to give them a reason. That reason could be, I need to go attend the wedding, the bar mitzvah, the something, the funeral of someone else. I need to go do this thing. And you can have your loved one admitted for 5 days only if they are already part of a hospice program. So I hope that answers.
I heard that Johns Hopkins Medicine is working to obtain FDA approval for the use of infusion pumps to more evenly deliver doses of carbidopa-levodopa to Parkinson's patients. Are you familiar with this? And if so, what could the benefits be? Would patients be able to utilize this method or something similar before it is formally approved?
Well, I got news for you. It's formally approved. So we don't need to worry about that. So I think what the person is referring to is the name of the product now is called Vyalev, Vyalev, Vyalev. And it has been in the works for years and years. This is what many people have asked for is why can't I get levodopa that stays at a steady level all day long? And that has been impossible to do in a pill form, but it's been in lots of clinical trials for years and years. And the first one, there will probably be others, but the first one was FDA approved October 2024, finally started being available, not yet for people on Medicare, but has been available for most of 2025 for people on other commercial insurances, but they're still figuring out how it's going to be paid for. Medicare has just recently in the last month said, yes, we will cover it, but that does not mean anything about what the copay will be. So huge caveat is we do not know what this will cost people yet. We are hoping that the drug company will recognize that and behave accordingly so that this technology can be available for people.
Is that AbbVie? Is that
It is.
AbbVie's drug?
It is.
So I think they do have a program where they will help.
Right now, yes, right now they're
Yeah.
helping, but it hasn't really been extended as far as I understand, and I could be wrong. But it hasn't been extended yet to Medicare recipients. And so how that's going to look, because that opens up a massive population. But the hope is that this could be an option for many people with Parkinson's, for folks who are having really difficult motor fluctuations where they're off, they're on, they're too high, they've got dyskinesias, then they go back down, right? This gives you the ability to have a steady level of dopamine during the day and a lower but still steady level of dopamine during the night while you're sleeping. So people are not waking up on empty and waiting for that first dose to kick in. This might be an alternative to deep brain stimulation for many people who would not otherwise be a good candidate for deep brain stimulation. It might be a middle ground, doing the pump for a few years and then going on to get deep brain stimulation. And actually my colleagues, so I am not a DBS, movement disorders neurologist, but I have wonderful colleagues who are, and they have talked about actually folks who've had DBS and then have gotten the pump after that, dealing with various different, complications and things. So it is a wonderful new tool in our toolkit. It's still levodopa, still the levodopa that we know and love and hate for all the different reasons. But it is a wonderful thing that we've been waiting for many, many years. And now it's just a matter of seeing how does that look in reality, insurance-wise, long-term outcomes-wise, all of that.
What can be done, excuse me, what can be done for a person with advanced Parkinson's disease if their caregiver suddenly becomes ill and needs hospitalization?
This is a great question. We try to talk about this so I have an interdisciplinary movement disorders neuropalliative care clinic. And a lot of what we talk about is it always feels too early to talk about these scary things, the what ifs, until it's too late. And so as much as we would hope that someone with Parkinson's has designated who is their decision maker in case they cannot make decisions for themselves down the line, who is their healthcare power of attorney, we also want, whoever that is, often it's their care partner, that care partner needs to also name a healthcare power of attorney. And if it's a spousal significant other pair, legally, I believe in all 50 states, if you don't have something on paper, the default is it's your spouse. And that may need to change as Parkinson's goes on, especially if there are cognitive changes. So we want to make sure that not only does the person with Parkinson's have documentation of here's who I want making decisions for me, and ideally a living will, other documents that say, here are the kind of decisions that I would want made. Here's what I value most. Here's what I don't want. If this is someone who would never, ever, ever want to have, a tube and a breathing machine, write that down and make sure that the person who may be in charge of making that decision knows that, right? And the same applies for care partners, is having advanced documentation to say, here is who I want making decisions, here's what I want those decisions to be within the realm of predictability, and having a backup plan. So I've had care partners describe it as capital T, capital B, the binder. The binder. There is the binder in which they have their loved ones' advanced directives, healthcare power of attorney forms, living will forms, copy of their most recent medication list, copy of how do I reach their doctor, who is their doctor, who's their primary doc, who's their neurologist, whatever, right? In case of emergency, call. Here is what their usual schedule looks like, right? And does that take time and energy to make that in the first place and to keep it updated? Absolutely. But once you have it, and if the binder is electronic, all the better to share it with all those people who might need to know, because then you make a phone tree so that if there's something wrong with care partner number one, the air traffic controller, it's just one call to the next person on the list. They know the binder exists. They know where to find it. They've got it on their phone or their tablet or their computer or there's something, and someone hopefully is able to step in.
Okay, just a couple more. With with cognitive decline, my husband gets so defensive if I point out to him that he's stooping over or speaking softly and other related issues. What should I do? Keep quiet? I've tried different approaches and nothing seems to work. He always comes back with reasons why he is doing the behavior.
So this is super common. And the reason is because even though we might look at a person with Parkinson's and go, oh my goodness, this is not normal. You can't be stooped over like that. Stand up. Because this is such a slowly progressive, insidious disease, their brain is giving them the feedback that everything is fine, right? Because this doesn't happen in a split second or overnight, right? It's thankfully, this is not a stroke. We don't go from 0 to 60 or 60 to 0. Things are slowly changing, which means that the brain's amazing ability to compensate and to acclimate, this is the downside of that, is they don't necessarily see those changes. And so it does take external cues and it does take nudging, all of the things. And that does become annoying because if you think that you're fine and someone is constantly going, stand up, you're not doing this, talk louder, I can't hear you, it's not me, it's you, right? You'd be really frustrated too. So I think leveraging the power of humor wherever you can is really, really helpful. Finding some keyword, some safe word that you can use that your loved one responds to, and it may need to change over time. But I will give you one example that I love. I have a lovely couple. He actually has one of the atypical Parkinsonisms, but he has a very hard time walking and he stoops over. And his wife told him to basically pelvic thrust. And if he pelvic thrusts, he remembers to stand up. And so she calls it boinging. And so instead of saying stand up, you need to stand up, she'll just say boing it. And he will boing it and stand right up straight and giggle and then move on, right? So whatever, if boing it doesn't work for you, it's fine. Maybe it's not safe around the kids or the grandkids. You do you. But find your boing it equivalent. Find something, know that it may need to change over time. But this is the thing, and I would just say, give some grace to your loved ones, healthcare providers, because, for example, I think one of the most notable things is with dyskinesias, because someone who's having dyskinesias may not recognize it at all. And I will see patients in clinic with me who are literally sitting and going like this, and the whole time, coming out of their seats. And their family is sitting there with them. And I will go to the person, do you ever have any involuntary movements? Do you ever have any wiggly, fidgety movements or any dyskinesias? And the family is like, oh my God, how blonde is she? She's doing it, right? And I'm like, I know they're doing it. Like I said, this is the only thing that I notice. I am useless at a party. I see the dyskinesias. What I'm asking is, how much
Let's
is the
see.
person's brain registering what they're doing? And that is helpful for me to know. Is watching someone walk in the hallway, I know that in that first moment, they're going to stand up tall, right? If they can, if they're aware of it, they're going to stand up tall. They're going to swing their arms like their therapist told them to. But then when they turn around and they're walking back, and if we start to have a conversation, I'll get at least a bit of a snapshot of what stuff really looks like underneath. That's what I want to see, is when their guard is down, do we start to do some of this as soon as we're walking? So we know that it happens and we know that it's on care partners to constantly be nudging, but use humor, recognize that it's not them, that it's got to be so frustrating to think that you are okay and to constantly be told you're doing it wrong. You're doing walking wrong. You're doing talking wrong. when your brain is telling you that it's just fine. So we have to find some way around it that doesn't feel like criticism. So humor.
Why is it so difficult to find Parkinson's disease caregiver support groups? I didn't know that it was so difficult, but maybe where this person is.
Depending on where you are and depending on what you're looking for. So there are absolutely regions of the country where it is just kind of a desert. Especially if you are in a state that has square corners, you may be in trouble. You may be very lonely with your Parkinson's. If you are in a Dakota, if you are in Wyoming, if you are, sort of mountain area states, there are very few movement disorders neurologists. There are very few neurologists, period. And so it can be very hard and feel very isolating that even though we expect that the prevalence of Parkinson's is just the same out there as it is everywhere else, 1 to 2% of people over the age of 60, 3 to 5% of people over the age of 80. So if you're in a less populated area, there may be fewer people, but there are still people. But it often takes, I've had folks where I'm like, I hate to tell you this, but if there isn't a support group in your area, it might be because you're the support group leader and you got to start it. And I promise that if you start it, people will come.
Let me also say that there are two support groups right here in Baltimore that Zoom. There's one for Parkinson's caregivers that Zooms once a month, and another one for people with Parkinson's that Zooms once a month. And if anybody wants information about that, you can go onto the MAPS website, click on support groups, and just scroll down and you'll find it.
I would also say that if people are outside of the Baltimore area, so Parkinson's Foundation, you can look up support groups. If you go to parkinson.org, there's an in your area little search bar. You can type in your zip code. It will find some, not all, support groups near you. But all of the different organizations support different ones. So Parkinson's Foundation, Davis-Phinney Foundation, American Parkinson's Disease Association, or APDA, PMDA, Parkinson's and Movement Disorders Alliance. I will get all of the acronyms confused. There are the independent Parkinson's associations or independent Parkinson's network, and those are smaller regional ones that offer things. So this is one of the few places in Parkinson's where Google is your friend. Don't believe the other stuff. Don't believe whatever it has to say about protein and leave it to and all the other things. But to find resources, that's okay.
And one last question. Do you have any suggestions regarding private pay concerns for home care?
I wish things were different. I think it's a really, really challenging situation. I have seen all manner of caregivers in my clinic, in my own family. I think there are pros and cons. Some people will say, well, what about agency versus sort of finding your own individual person? I think just to speak briefly to that, sometimes if you know someone who knows someone and they have an amazing caregiver, often that's kind of the best is word of mouth, right? And finding someone, especially if they've been part of the Parkinson's community, they may know more about Parkinson's than anyone else that you're going to find. But if you're going just sort of out of pocket without an agency, do a background search. Even if they come highly recommended, do a background search. Make sure that if they're going to be driving a loved one around, you've searched and made sure that they're a safe driver, right? But it also means that if they get sick, if they have a family emergency, you're on your own, right? Unless they got a friend and you trust that friend. Whereas with an agency, you're usually paying even more. You're paying a premium. The caregivers are getting paid less because the agency is taking some of that, but they are doing a background check of some sort. And it means that if your caregiver has a family emergency, something's going on, the agency is responsible for sending you someone else. Sometimes what that looks like is, especially depending on how many hours you're using, if you're not using very many hours, you may not have consistency. So if you're someone that's kind of just dipping your toe into, okay, fine, we'll see how this goes. We'll let someone in, but I just want them 2 hours on Monday and then an hour here on Wednesday, and then the occasional Friday, you're not going to get the same person, because that person is probably being paid $15 an hour, and they have to have consistency. And so the agency is going to give the caregivers consistency over trying to accommodate a very kind of fiddly schedule. But if you can have, I want someone 6 hours a day, this many days a week, that increases your chance of getting a person who's stable, being able to build a relationship with them. And it does not mean that it's easy. You will still be air traffic control. You will still need to teach them about Parkinson's, about your house, about the yeses and the nos and the do's and don'ts with your particular loved one, and they will need to build a relationship with your loved one. But hopefully that takes some of the burden, the moment by moment burden, off of the care partner. And if you find that person and there is a relationship, people with Parkinson's and Lewy body are much more likely to take the meds, to do their physical therapy exercises, to go for the walk around the block with the caregiver than they are with their loved one. So what are the things that they won't do for you? That's where you focus your energy with the caregiver. For whatever reason, people will be nicer and more agreeable to doing those things with someone who is not their loved one. And it's just much more easy to go, no, I'm not doing that, to the people that they're closest to.
Well, that's all the questions. Thank you. I don't even have words enough to tell you thank you, because
No.
this was terrific. I mean, really, helpful in so many. Oh, wait a minute. Here's a question. Oh, thank you. And thank you, Judy. Well, you're welcome. And thank you to all of you. And thank you to you. Thank you to you, Dr. Fleischer. I mean, really terrific.
Thank you
Thanks.
so much.
And I do want your email, because I am going to have questions. I'm going to
Absolutely.
listen to this myself again. Oh, wait a minute. Here's something else. Incredible. Wait a minute. What's this say? Incredible. Thanks so much for what? It
Oh,
cuts
for
off
being
right
patient with us.
there.
Oh,
Everything. Incredible. Thanks so much for everything. Yeah.
I will absolutely. I will shoot you an email so that you have my email, and I will turn the slides into a PDF so that if people want copies of the slides, you can totally share them out. I'm happy
I
for them
do.
to
I
share.
definitely do. Is there anything published yet? Any book or anything? You talked earlier about that that we could.
The
I mean, I'm going
curriculum.
to ask the care partner, the support group facilitators to make sure they watch this.
Oh, thank you
Um,
so much.
well, I will, sure.
So the curriculum isn't publicly available yet because
Okay.
we're still testing to see, like, does this actually make a difference, which kills me. But the only way to show, like, yes, this actually works is to compare giving one group the whole thing and one group an abbreviated version of the thing and testing and going, no, look, the whole thing makes a difference. Or maybe it doesn't. Maybe the abbreviated version is just fine. But that's kind of how we see. But as soon as it's done, so the grant goes through we're in year 3 of 5, and hopefully we'll start having results as people go through in these waves. But as soon as we have data, if that data shows that this works, the goal is to make this available, and the goal is to adapt it and continue. The feedback that we get from care partners in it is, this is great. And also you need to talk more about this, right?
Mhm.
Is just, this could, be adapted forever, but we want to be able to make a Persevere for people living with Parkinson's themselves. Because one of the things I hear all the time is someone getting a diagnosis and they're like, yeah, this is all good, but it's static as soon as you start talking. And if I could connect people with someone who's been through it and come out the other end and is thriving with Parkinson's and can talk about what this is like, that would be huge. So that's the next step that we're working towards as well.
It'd be huge for you, and would be huge for everybody who's living with this. I
Yeah.
mean, really, yeah. So thank you again. I look forward to getting your email. I look forward to getting the slides. I look forward to telling all the facilitators to watch this, because this was beyond terrific. Just thank you.
Thank you so much. Have a wonderful
Thank
night,
you.
everyone.
You too. Good night. Good night, everybody.